I'd like to start off with a review of the reproductive system disorders. We already started this in class, but I decided to start from the very beginning because this is also a good review for you for final exams. So these are the list of topics that we have today. This is basically copied and pasted from the handout I uploaded on Canvas. You could see that the first 3 bullets up here are the disorders of the male reproductive organs, and the last 1, 2, 3, 4, 5, 6 are disorders of the female reproductive system. So again, please refer to the COPSED handout, and you'll see more details about each of these topics. As discussed in class, we started with the congenital disorders like the spadias, which is basically the abnormal location of the urethral meatus or urethral orifice. This is the normal location, as we know, and hypospadia is when the meatus is on the undersurface of the penis, or we call this the ventral surface, and on the dorsal surface of the penis, that is what we call as epispadia. Not included in this slide is paraspadia, P-A-R-A, where the location of the urethral meatus is on the side, on either side, the right or the left side of the penis. And once again, there's not much of a clinical relevance of these disorders because, although it may look inconvenient, this can easily be surgically corrected. I had a student who asked me before, what about infertility? Would it lead into infertility? I guess you could say that too, because if the location of the urethral meatus is, say, right here, or even as more proximal, like over here, it would be hard to ejaculate into the vagina all the way through the cervix, because basically you're spilling semen just on the walls of the vagina. But again, something like this can be easily corrected by surgery, especially if it's diagnosed early. Another congenital disorder of the penis and the urethra is the abnormal connection between 2 hollow organs. This is the rectum, and right here is the urinary bladder. And the arrow is pointing to what we call as a fistula, an abnormal connection between these 2 hollow organs. So you could just imagine, whatever is in the rectum can easily go into the urethra. And you know what that means, UTI, frequency to UTI because of bacteria in the rectum can easily go into the urethra, and therefore can even ascend up to the bladder. So here is another example of a fistula. I'm not going to show this later for the female reproductive system, but you could see that it can also happen. This is what we call as the fistula between the uterus and the urinary bladder. This is a vaginovesical fistula between the vagina and the bladder, and this is a vagino-urethral fistula. Fistulas can happen congenitally, like I've said, but also this could be a result of trauma. This could be a result of surgery that has gone awry. When there is injury, the body will heal, and sometimes the body heals crazy. Instead of healing completely, there could be abnormal growth of tissues that can happen as we heal, and that could result to a fistula. This is another congenital abnormality. I'm not sure if you're able to visualize it, but this is phimosis. This is a type prepuce or a type foreskin. These individuals are therefore prone to infections, but also painful erections. And the treatment is circumcision. Okay? So removing the foreskin to expose the glans penis so it's no longer subjected to painful erections. Here's another one. This is what we call as a stricture, okay? A narrowing of the urethra. And this could be congenital, but at the same time, this could be acquired as a result of trauma, as a result of healing, as a result of scarring. And since the urethra is the common passageway of sperm and urine, then that could be a double problem in urology. Here is, I think we stopped in this slide. This is priapism. This is what we call a sustained erection. On this side of the image, you could see normal erection mechanism. You have the arterial blood flow into the penis, where the penis becomes enlarged, erected. But in the middle slide, this is what we call as an augmented arterial blood flow, that where venous drainage is very inefficient, and that can cause the sustained erection, which could be painful, of course. And even worse is if this does not drain completely, okay, it can have much worse complications. So this is an emergency treatment for priapism. As you can see, we're making an incision directly into the penis to release the pressure by allowing venous flow, or what we call as creating a shunt mechanism. And then we have the slide on erectile dysfunction, which is, of course, there's many articles about it. You could click on this website. It will lead you to an article that has a really nice discussion about erectile dysfunction. On the list that I have here, there are two types of ED, also called impotence, primary and secondary, and the different causes of primary and the different causes of secondary. You'll see here that secondary, there could be an underlying condition like a vascular disease, hypertension, even as a result of medications, endocrine disorders, trauma, of course, and also psychological distress. So here are the differentiation between ED from a psychogenic cause and ED from an organic cause. So if it's psychogenic, it's sudden in onset, okay? And organic is gradual and it gets progressive. So it could start off as they do have an erection, but then it's not sustained, and then it just progresses to complete ED. Psychogenic is also intermittent. It's situational. It's the environment, the atmosphere affects the ED. They could start with an erection, but again, they will not be able to sustain it. They do have excellent nocturnal erection. Okay, so even without external or conscious stimulation, there is erection. And psychogenic ED is responsive to medications. Organic, on the other hand, is aside from being gradual and progressive, they do not respond well to medications. Okay? It's also shown that ED erection is better in standing position than lying down. Okay. Here is another congenital abnormality. Seems to be out of place. They should have been just before ED. This is what we call as cryptorchid. Oops, sorry about that. Cryptorchidism. Okay. So cryptorchidism is literally, it means, let me just type that for you. It means hidden testis, because the root word crypt, okay, like encryption, right? It means hidden or hiding. And then orchid is the root word for testis. And of course, ism is a suffix for condition. So this is cryptorchidism, hiding testis, but they're not really hiding. They are undescended, because in embryology, you will learn that the testes are originally are intra-abdominal in location, just like the ovaries were. But when the fetus starts secreting testosterone hormones, the testicles slowly descend until it reaches its final destination, which is the scrotum. Okay? Preterm babies, of course, one of the things that we check immediately is if the neonatologist will palpate for the scrotum and make sure, or checks if the testes are in there. Since they didn't have the full 40 weeks of fetal development. And if they don't, the management is pretty conservative in the beginning. We just wait for the testes to descend. But of course, in other cases, this might need surgery. Okay? Needs to be corrected because it's it results to infertility. You know, sperm cells cannot mature in a very warm environment. Okay? Remember, in the scrotum or outside the body, the temperature is 3 degrees lower than the core temperature, and that's what the sperms need to mature. Another reason, and not just for infertility, cryptorchidism is actually one of the risk factors of testicular cancer, okay, which we're going to look at in the next slide. Hydrocele, what you can see here in this image is, you see that 2 hands holding on, that is actually the scrotum. It's swollen, it's filled with fluid, and that is called a hydrocele. Every time you see the suffix cele, it means swelling, it means herniation, it means accumulation of fluid in a sac that has potential to accumulate fluid. So there are many causes of hydrocele. One of them, of course, would be infection, inflammation, and what else? Infection, inflammation, and maybe it could start off as an herniation in the from the abdominal cavity. So let's see. We see the treatment that they're doing here is, of course, to extract or to remove the fluid from the scrotal sac. But of course, we have to find out the root cause of where that fluid is coming from, because it can always have a rebound accumulation after extraction of the fluid. Okay. So one of the things that I just need to remove this text right here. One of the things that can happen with a hydrocele is this. You see that the arrow showing you that the testicle is twisting. Okay, what is that called is a testicular torsion. Okay. Let me type that once again. Testicular torsion. Okay. Testicular torsion. Just want to make sure you guys see that because it's a little blurry on this area. Okay, so this is a medical emergency because if you remember, this is the spermatic cord, and what runs in the spermatic cord is not just the vas deferens where the sperms pass through, but the testicular artery, the testicular vein, testicular nerves also are in that spermatic cord. So think of it as strangulating the testis. Here is showing you that they're untwisting the testicles, and I don't remember the label of this image, but we could just imagine that this is already a necrotic testicle because it's black in color. So let's assume that this suffered from ischemia and necrosis and therefore needs to be removed. If it's not necrotic, then from the case study we did earlier, we could untwist it in the hope that it's not gonna twist back. Okay, let me clear my text right there. Next, we have, to my next slide. Speaking of, we're still in the testicle topic. What we have here is testicular cancer. Okay? Testicular cancer is a malignancy that is common in younger men. Now, when we think of the other cancers, we always think that advancing age is the risk factor. This one can happen in the young, as young as, 15 years old, as the slide shows you. There are many different types of testicular cancer. A couple here are listed: seminoma and teratoma. And the most common symptom of testicular cancer, like many other cancers, is of course a lump or a swelling in the area. Aside from that, aside from lump or swelling, early puberty is also a sign of testicular cancer. Breast soreness or growth or lumps in the breast of the male. And of course, in advanced symptoms where you expect the cancer to be in an advanced stage and there's metastasis or spread of cancer, then you could, there's definitely other signs and symptoms like lumps in the groin, the inguinal area. If it has metastasis to other parts of the body, like the liver or the bone, then expect signs and symptoms pointing to liver and bone. Like any cancer, treatment for this or how to manage this would be there's surgery, there's chemotherapy, there's radio, and a lot more cancer therapy management that we have nowadays. Speaking of cancer still, we have here cancer of the prostate, okay? So as we know, the prostate is a gland that surrounds the first part of the urethra. Now, whether it's cancer or another condition is benign prostatic hypertrophy, so BPH, the signs of symptoms of this two are actually similar because the organ affected is the same. So when it's enlarged, when it's cancerous, it's squeezing on to the first part of the urethra. So signs and symptoms are urinary. There's retention, there's hesitancy for either, there's dysuria, there's nocturia, waking up at night, there's blood in pee, incontinence, and frequency for either, okay, BPH or prostate cancer. However, when there is pain in bowel movement, that would be more of prostate cancer, okay? Because that could tell us that the cancer has spread to a proximal organ, which are the bowels. When there's bone or pain or tenderness, that's also prostate cancer because we can expect that the cancer has already spread in the bone, it has metastasized. So that would be the difference between the two. Now, another way of differentiating this two diagnoses is doing a blood test known as the prostate-specific antigen. It is especially high, there are high levels in prostate cancer. And by doing ultrasonography, transrectal or across the rectum sonography, we could differentiate lesions pertaining to benign prostatic hypertrophy or hyperplasia. You might see that as hyperplasia instead. And lesions of cancer are also obvious in ultrasonography. So still BPH and prostate cancer. The diagnosis is, of course, signs and symptoms are very helpful in diagnosis. You know? And we already listed those diagnoses. Upon physical examination, we do a digital rectal examination. So this is a glove digit inserted through the anus and into the rectum, because this is where you can best access the prostate, okay? And we can check for enlargement of the prostate, a consistency, if it's hard or soft, and if it's tender. That's one way of diagnosing. This, by the way, becomes part of the annual physical of a male once they turn 50 or earlier if, again, they show signs and symptoms. We can also do a urinalysis because, again, we want to rule out a UTI over a BPH or testicular cancer. Creatinine, we want to rule out kidney disease. Maybe, you know, there's hematuria, remember, that could be a sign of an underlying kidney disorder. And the PSA, which you mentioned earlier. Now for the management, depending on the signs and symptoms, we could just do watchful waiting. We could do medications, like for BPH, most medications are what we can general classification would be anti-testosterone in nature type of medications. And then of course, surgery if the obstruction is already very significant. Okay, so that's it. That's a quick summary or review of our male reproductive disorders. We have not started on the female reproductive disorders yet, so this one we'll try to take it a bit slower. The following are medical terms that we will understand in OBGYN disorders, okay? Amenorrhea. So every time you see meno or men, it always pertain to menstrual period. Every time you see rhea, it means discharge or flow. Remember diarrhea, okay? So amenorrhea, adding the prefix a to menorrhea means the absence of menstruation, also called a missed period, okay? So this one is a very common symptom in OBGYN, and it's commonly due to hormonal disorders. Stress can cause amenorrhea as well, neoplasms or new growths, and of course, pregnancy. Then there's metrorrhagia. Raja, think of hemorrhagia or hemorrhage. Metrorrhagia is bleeding in between periods. So it's as if you're having your period too often, but what you do have is like intermenstrual bleeding. There's hypomenorrhea. So we have hypo, reduced menstrual flow, compared to oligomenorrhea is infrequent menstruation. So instead of the typical every 28 days, maybe you have it every 40 days, every 50 days, a couple times a year. That's oligomenorrhea. And polymenorrhea is increased frequency of menstruation. So, maybe you have it every 15 days, which sucks, right? Every 20 days instead of the typical 28 days. Menorrhagia is prolonged and heavy bleeding during menstruation. Okay, so these are very important terminologies. And to establish that, when you're doing your OBGYN interview, you don't just say, can you describe your menstruation? Because individuals might just think that their pattern or their menstrual period is normal for them or is regular for them. When you do your interview, you always ask, how many days, when was your last menstrual period, how many pads a day, is it heavily soaked, moderately soaked, do you have intermenstrual, or do you bleed in between? So it's very precise, and then you can establish what medical term applies for that pattern. Dysmenorrhea, you have the prefix dys, which means bad or abnormal or difficult. So we always, in layman's term, we just say cramping, right? And dysfunctional uterine bleeding, or DUB, this means like there's the pattern is it's like a combination of the above. Sometimes it's every 28 days, sometimes it's every 15 days, sometimes I don't have it for months, and then when I have it, sometimes it's heavy, sometimes it's not. So it's very irregular. Now that is not, of course, that could be a sign of an organic condition, but that is also present at menarche, at the beginning of menstruation. When you ask for menarche, you ask, how old were you when you first had your period? Okay? Or the DUB can also be at menopause, because at these two events, the body's still adjusting or trying to establish the pattern of menstruation. When you have your menarche, it's not going to be regular right away. When you have your menopause, it's not just waking up when you turn 50 and then it stops. Sometimes the perimenopausal period is a whole year. And again, there are organic causes of DUB like the ones listed right here. Okay. So anyway, for the next disorders, female reproductive disorders, we're going to discuss the signs and symptoms are a variety of, or a combination of this, or one of these, or a combination of this. Okay. There's no one specific feature for one specific disorder. So our first here is uterine prolapse. Okay, so you could imagine the uterus prolapsing or coming out of what orifice will it be coming out of? The vagina. Okay, just like a cystocele where the urinary bladder is going to come out of the urethra, rectocele is the rectum is going to come out of the anus. Okay, so this uterine prolapse is, where's my picture for that? Right here. You could see the uterus coming out of the vagina. So risk factors, normally I would ask, oops, I do have a picture right here. That's the uterus coming out of the vagina. Risk factors, let's see. Multiple pregnancies, advancing age, maybe overstretching of your ligaments that are supposed to support your uterus have stretched out, like a rubber band. If you stretch it too much, because of when you stretch it too much, it loses its elasticity, it loses its tautness. So that's a uterine prolapse. Let's say you have a 48-year-old patient who's gravida 14, para 13. That means has been pregnant 14 times and has given birth 13 times. That's a lot of strain to the ligaments that are supposed to hold the uterus. Okay, for someone like that who's also seeking, a permanent option for contraception, maybe the treatment is hysterectomy, removing the entire uterus. That is, of course, surgical management. Doesn't need the uterus anymore. 48, 13 children. Maybe there are fibroid tumors in the uterus as well, so might as well just take out the whole thing. This image shows you the normal posture of the uterus. This is the vagina. This right here is the bladder. Right here is the cervix, and you could see the uterus is flexing upon the urinary bladder. So what you could see in this side of the slide is abnormal postures of the uterus. Okay, here is the uterus, still in the same view, lateral view, but the uterus is leaning back against the rectum. And here it looks like, oh, this is a normal posture, but the cervix is not facing down the vagina, it's facing the back of the rectum. Here is a retroflexed, or the uterus is flexed backward. Okay, there's not much clinical significance of this, but they are associated with really painful that's redundant, dysmenorrhea during periods. This can happen before. This can also happen after pregnancy. But for some women, they actually have this to begin with, and then when they get pregnant and deliver the baby, somehow when the baby passes down or passes out of the uterus, it flexes and normalizes its position. This has actually happened to me with my firstborn. I used to have very bad dysmenorrhea before I had my firstborn. And then when he was born, it's like, boom, no more super painful periods. And my OB explained that, when your baby was born, your uterus somehow untwisted or flexed down into its normal position. So I love my son so much for doing that for me. Okay. So this is quite common, about 20 to 30% women, and it could be congenital, pregnancy, and childbirth. But once again, pregnancy or childbirth can also correct an existing abnormal posture. Next, we have inflammation of the female reproductive tract. So this is an image of a normal or healthy reproductive system. And on this side of the slide, you can see you have this yellow stuff here on this side. Those are representative of abscesses. So it could start off as cervicitis, or inflammation of the cervix. This might as well be from a sexually transmitted infection. And then it could ascend up the uterus. So now it's endometriitis, and then going up into the fallopian tube. So that's salpingitis. Eventually in the ovaries, that's oophorytis. So this massive infection now, we call it pelvic inflammatory disease, or PID. Okay, and it could even extend all the way to the peritoneum, or the abdominal cavity. So the infection has extended into the bowels. Okay, the risk factors for PID include IUD. If you remember IUD, that little T-shaped device that's inserted inside the uterus, but not so much anymore with the advancement of medicine. It used to be a common complication of IUD. Abortions can also cause pelvic inflammatory disease, especially if it's septic abortion. You know what they call that, like basement abortions, where they use contaminated equipment. And of course, pelvic surgery, and that could be a lawsuit, if they did not follow any antiseptic precautions. Treatment, management, not surgery. Remember, this is infection, so antibiotics. And morphine, manage the pain. So the most common cause of PID is chlamydia, which used to be the most common sexually transmitted infection, but now it's HPV. And also gonorrhea, which used to be the most common STI before chlamydia and before HPV. Okay, so how do we diagnose PID? With that massive infection, you could expect a lot of pain, tenderness on bimanual examination, bleeding, urinary disorders, nausea and vomiting, and of course, fever. There's also, this picture shows you dyspareunia or painful intercourse during or postcoital or after intercourse. That's also a sign of PID. Okay, this picture shows you, a nurse or a doctor doing their bimanual examination. So there's tenderness. This is pus in the cervix, which is viewed via vaginoscopy, or you can insert this cotton tip swab into the vagina. As you can see, there's pus collection at the tip of the swab, and that automatically tells you there is infection going on. Okay. And that's a picture of a bimanual examination. So with a gloved hand, internal examination, and of course external examination that could also check for tenderness in the adnexa, or the organs lateral to the cervix and the uterus. So labs, oftentimes it's really enough to do this inspection, palpation, examinations, this cotton tip assessment of your symptoms. But of course, we can collect a specimen and then culture that specimen, so we will know what type of bacteria is causing the infection, and then we could do a sensitivity testing and find out what is the best antibiotic that where the bacteria will be sensitive to. So the complications of PID is, this picture shows you a lot of scarring, adhesions, fibrosis. This might well be a scarred fallopian tube. Right? So that's a complication, and it can cause infertility because, well, sperms will have a hard time finding their way into the salpinx or fallopian tube, and therefore they can't find the egg to be fertilized. Or even if the sperm finds the egg and gets fertilized, remember that the fertilized egg will have to find its way back to the uterus to implant. But with all this fibrosis, with all this adhesions, they might not find their way into the uterus and just implant in the salpinx, which is going to be an ectopic pregnancy. Okay. Chronic pelvic pain is also a complication of PID. Like I've said, ectopic and tubal pregnancy, and of course, infertility. Okay. Now this picture you have here is an electron microscopic photograph of your yeast cells. The medical term for that is candidiasis or moniliasis. So for those of you taking microbiology, you remember Candida albicans. Okay, that is the scientific term for the fungus that causes yeast infection. So the most common cause of yeast infection is not necessarily a UTI. This bacteria is one of the normal flora of our of the vagina. So there should be a normal balance between bacteria and fungus in the vagina, just like in other parts of the body that we have normal flora. But sometimes this balance is disturbed. Say if someone has diabetes, or if someone is taking antibiotics and they have extended their dosage or they were overdosed. So what happens is it kills the bacteria, and now the candida or the fungus will take that opportunity to overgrow. It's like they're saying like, oh, the bacteria is gone, we have more space to multiply. So they take over, and now there's yeast infections. And that could also happen, the other way around. Sometimes there's less fungus, normal fungus, and the bacteria will overgrow. So now you have not yeast infection, but you have bacterial vaginosis. So that's what happens when you have an imbalance of the normal flora, or when also you disturb the pH of the vagina. Okay. What showed up here is basically a copy and paste of a screenshot of the handout I uploaded on Canvas. it shows you the predisposing factors of candidiasis. You'll see here the use of feminine hygiene products, trauma, allergic reactions, and once again, antibiotic therapy. Okay. Next, what we have here are benign growths of or in the uterus. This is quite common. So we have here benign fibroid, that's fibroid. Please correct the typo right there. It's Fibroid, okay? Also known as leiomyomas, because myo means muscle, oma means tumor, and leo means smooth. Okay? The picture right here shows you the different locations of a leiomyoma. It could be found within the uterine wall. We call it intramural, subserosal, and the more common one is submucosal, so under the mucous membrane. Someone with fibroid tumors will manifest with pain, okay, low back pain, abdominal pain, constipation, of course, infertility, and heavy long menstruation. So if you remember from our first slide, the term for heavy or long menstruation is menorrhagia. Okay, but again, those lists, they're non-specific. This individual could also might as well be having polymenorrhea, and this menorrhea, with heavy long menstruation, you can expect the patient to manifest with anemia. Okay, so any signs and symptoms associated with anemia like pallor, weakness, fatigue. Okay. Risk factors of leiomyoma includes high levels of estrogen, nulliparous individuals. So from our case study, nulliparous means never been pregnant. Okay, so they're at risk for this growth because remember, if you've never been pregnant, you always have high levels of estrogen. In pregnancy, 9 months, you're free of estrogen. Imagine having 10 children. That's 9 months times 10. You have 90 months saved. You save yourself from estrogen exposure. Okay? Estrogen is an anabolic hormone. It builds, it builds tissue and it builds these tumors. Okay? So someone who has never been pregnant always have high levels of estrogen and therefore will allow, will stimulate the growth of these tumors. Okay. So treatment is, one of the treatment we've shown here is uterine artery embolization. Here is the image you see here, this blue mass here is a fibroid tumor and the blood vessel is feeding it with blood. That's why it's growing and growing and growing. So one way to stop the growth from growing is to create a fake embolus to block the blood flow into that tumor so that it'll stop growing. There's also surgery, whether it's a complete invasive radical removal of the lump or the mass, okay? Or we also have ultrasound surgery, ultrasound guided surgery. Hysterectomy is a complete removal of the uterus. So again, maybe there's other underlying problems like uterine prolapse. Maybe again, this individual doesn't want to have children anymore anyway, and it's super filled with the leiomyomas, and the leiomyomas keep coming back. So they decided to do a complete hysterectomy. And of course, we can go conservative with medications. Here is an image of an actual uterus filled with leiomyomas. Okay. So I flashed this slide, and probably the first thing you would say is ascites, because we have talked about ascites multiple times in different chapters. But that is not ascites. That is, the enlargement here is because of an ovarian cyst. What you see here is the actual ovarian cyst that was removed. Not necessarily from this patient. This must be from another picture that I copied from the internet. Okay, so that's an ovarian cyst. Here's another one. Okay, these are not isolated cases. This is, believe it or not, quite common. Maybe not so much in the United States, but in other places and other areas where they don't have access to good health care. They don't visit their doctor annually. They just assume that they're gaining weight. Again, because this does not obviously this does not grow over overnight. It takes years for something to build up like this, or maybe months, to say the least. So here's a picture of what could happen, or it could start off as a small follicular cyst. If you remember the menstrual cycle, it starts off with a small follicle, and every month this happens. The follicle becomes a vesicular cyst. The buildup of fluid within the follicle. At the 14th day, there's pressure, and that will burst to release the egg at the time of ovulation. So sometimes that cyst will just remain, and for some weird reason, it just keeps growing and growing with fluid. It starts off something small like that, and imagine that it can actually grow big like that. I have a short clip here from the movie My Big Fat Greek Wedding. Not going to play this anymore, but feel free to do so when you check my PowerPoint. But Aunt Vola, I think, she was talking about her twin, which is a thyroid tumor that has teeth and hair and other types of tissue. Although this was a comedy, tumors like that actually exist. Okay, so one of the more common locations of dermoid, we call that dermoid tumors, which, by the way, was in our case study, is in the ovary, the most common location. So here's a benign tumor from the ovary. There's hair, there's teeth. Okay, the origin of the tumorous tissue is, like, think of stem cells that have the capability to transform into different types of cells, and somehow that those are the type of cells that developed in the ovary. Okay, so that's a dermoid cyst, a dermoid tumor. Other types of benign growths from the ovary would be an endometrioma, again a cyst, a cystadenoma, and we have it here, polycystic ovarian syndrome. So polycystic, this is the one that's like closely associated to our polycystic kidney disease. And of course, this is the one that is genetic. Okay, so out of the many, there's so many female reproductive disorders. So I've provided you with handouts, and also your book would show you a differentiation of all these disorders grouped into the etiology, the risk factors, the diagnostics, the treatment, and of course the complications. Okay, and many of them, I mean, we've seen in the first few slides, they do share a lot of etiologies, they do share risk factors. Diagnosis is history, physical exam, vaginal exam, bimanual, ultrasound. And I think I like posting that case study last week because it really shows you the details of diagnosis from etiology, risk factors, all the way to treatment and complications. This image shows you, look at that, the ovary. Look at this. That's the twisting of the ovary. So that was the case study, ovarian torsion. And we've talked about testicular torsion just a few minutes earlier. That can also happen in the ovaries. Again, for just unknown reasons, or it could be because of a follicular cyst. As the cyst starts to grow, the growth of the cyst also started the twisting of the ovary. We also know now that it's more common in the right than in the left because there's more space on the right side to allow the twisting. On the left, there's the sigmoid colon, which limits the space of the left ovary. Okay. Next, very important, endometriosis. From A and P, the endometrium is the inner lining of the uterus. So right here, if you follow my cursor, the inner lining of the uterus is the one that builds and becomes vascular and glandular every single month. That happens to the endometrium. It thickens because every month it's preparing to host an implanted, for the implantation of a fertilized egg. Okay? And then if there's no fertilized egg, we shed it off, and that is the menses. Okay. So imagine having endometrial tissue elsewhere, aside from the endometrium, on the fallopian tube, on the ovary, on the peritoneal cavity, in the cul-de-sac over here, called that the Douglas pouch. In the urinary bladder, you have endometrial tissue. So that means every month, this tissue elsewhere, outside of the uterus, are also getting stimulated, are also being affected by your hormones. So much cramping happening there. And then there's also bleeding every single month from this endometrial tissue elsewhere. So if it's not being shed off like the menses, the blood can be trapped in these areas. Sometimes we resorb them. If they're small, it will be resorbed by the body, but it can also irritate the surrounding tissue, and then it can also form cysts. So the two most important symptoms of endometriosis is pain, infertility, and dysmenorrhea. Okay? That's actually the triad of endometriosis: pain, infertility, and dysmenorrhea. But even if those are the classic three, those three are pretty much non-specific still and can be in other diagnoses as well. So pain elsewhere, not just vaginal, not just uteral. It could be anywhere where you have endometrial tissue. Irregular menses and infertility. Meds could be conservative. Meds could be pain, of course, laparoscopy, okay, to diagnose the location of endometrial tissue. Where are they scattered outside of the uterus? And of course, treatment is ectomy, remove the endometrial tissue, probably remove the organ if there's so much endometrial tissue in that organ. Or, so this is laparoscopic surgery, by the way, okay? So they're trying to look at, oh, you have endometrial tissue on top of your ovaries. Okay? That could easily be visualized. And then another one for a diagnosis is a procedure called dilation or dilatation. Some books will call it dilatation. We call it DNC. Okay, dilation and curettage. So curettage is, we insert this instrument called a curette, and I know it sounds morbid, but it's literally scraping off the inside of the uterus, trying to take out the endometrial tissue, because if not, there's going to be just a lot of bleeding. So we scrape out the endometrial tissue. In the olden days, they called it dusting. Layman's term, the women called it dusting and cleaning. Okay, of course, we don't call that anymore. Next, cancers. We've talked about cancers for so long. Signs and symptoms are pretty much the same: lumps and pain. And of course, as it progresses, there's more. Let's talk about one of the more common cancers in the female reproductive structure, cervical cancer. So the cervix is right here, the opening, the neck of the cervix. It used to have a really high mortality rate, but because of the PAPS test, or the Papa Nicolau smear, which is done every 3 years, we can have an early diagnosis of cervical cancer. And as you know, early diagnosis means better outcome or better prognosis. It's now done every 3 years. It used to be every single year. They changed that to every 3 years because they said studies show that even if after your last normal pap smear, even if cancer starts to develop, it would take 3 years before it can be detectable by pap smear. Okay? Of course, if you have an abnormal pap smear, it's still going to be every year. So it starts off as asymptomatic, like some cancers, and then there will be abnormal vaginal bleeding. So any of the ones we mentioned in our first list of signs and symptoms. Discharge, may be different in color or odor as well. And once it metastasizes to other organs, then you can expect to see more signs and symptoms. So if it's metastasized to the bladder, expect urinary symptoms. If it metastasized to the rectum, expect bowel irregularities, constipation, blood in stool. Gardasil. Okay, we have Gardasil here because one of the most common risk factors for cervical cancer is HPV, and Gardasil is a vaccine for HPV. We have now Gardasil 9, which is effective against many strains of many strains of HPV that are associated with cervical cancer. And by the way, HPV is very, very common. When you have patients who turn out to be positive to HPV and they panic and all, make sure you educate them, because there are many more HPV types that have no association with cervical cancer again. And usually this is like a flu, or all they have to do is strengthen their immune system, lifestyle change, nutrition, and they can overcome an HPV infection. Okay, although it just like the flu, it can keep coming back. So I think what we have now for Gardasil is it can be given as early as 9 years old for both girls and boys. Okay. And by the way, it's important to know that a Pap test now includes an HPV test. Pap smear used to be just purely Pap smear, but now Pap smear includes an HPV test. Another cancer is ovarian cancer, which has a high mortality rate because, again, usually the diagnosis is late. It is frequently asymptomatic until it has advanced the stage and you start showing signs and symptoms, and that's when you start going to the doctor. Okay? There are no routine screening tests that are available. So we don't do ultrasound every year just to screen ovarian cancer. But when we do bimanual pelvic examination every year with the OBGYN, it may be possible to diagnose it early because of pain, tenderness during examination. And our last would be disorders of the breast. So for breasts, we always think about breast cancer right away, but there are benign conditions of the breast. This is a screenshot from the handout. Please read through this short list of bullets. Breast abscess, there's infection, of course, but you can expect to see this in women who have diabetes and undergoing steroid therapy because they have a weakened immune system. Abscesses are large and therefore they do not respond to antibiotics as well as just regular infection. There's also fibrocystic breast. There's smooth muscle tumors in the breast, kind of like the leiomyomas in the uterus. And of course, breast cancer, which is the most common cancer in women between the ages of 25 and 75. There are many different types of cancer. It could be lobular, ductal cancer. There's even fatty tissue cancer in the breast. Okay. The most aggressive is the ductal carcinomas. What else can we say about breast cancer? So there's different staging for cancer depending on the type of cancer. We want to diagnose it as early as possible. Fortunately, we have screening tests for cancer, like a mammogram that can detect lesions as small as, I think, 5 millimeters, if I'm not mistaken. 5 millimeters mammograms. Biopsies, ultrasound, and of course, don't forget self-breast examination. It's your job to educate your patients on how to do self-breast examination, facing the mirror in the shower, laying in bed, palpating all the way around the nipples, around the breasts, all the way to the armpits. Look for signs of lumps, asymmetry, skin lesions, discharge from the breast, dimpling. An inverted nipple or dimples on the skin of the breast could be a sign of a tumor that's pulling the skin inwards. And that is one of the obvious sign of something else is growing inside. And unfortunately, it could be a cancer. Okay, so we diagnose it based on the size of the tumor, the lymph nodes that are affected, and if there is metastasis or spread of the tumor. Treatment can be anywhere from a simple surgery, a lumpectomy, which is removal of just the lump itself, or radical mastectomy, which is removal of the entire breast and the underlying tissue. But now we have more conservative treatment for breast cancer. There's, of course, radiotherapy, chemotherapy, gene cell therapy, stem cell therapy, immunotherapy, hormonal therapy. So mortality and morbidity has decreased significantly, as long as we, of course, do our early screening. Okay. And I think that's it for our reproductive system and for the rest of the semester. So I prepared this just as a option, a plan B in case I'm not able to show up to class today. But I'll be posting this in case you want to do a review or a replay of our lecture to prepare you for the finals. Thank you.